The reason for that is that there has been a lot of lack of awareness about pediatric endocrine disorders. So we started off with workshops and practical courses which were held across the country. Then we realized that it was very difficult to cover large areas because it is so much logistically difficult. So we started off with social media, particularly with YouTube. And then we started our fellowship program. Now we have got, today we have now got around 10th fellow. Dr. Dhwani has joined as well. So we have got now 10th fellow in our system who has joined the CDR program. Then we started off with our online courses and then finally textbooks and mobile applications. So we have tried to take forward in terms of making it easy and easily available and accessible in that regards. We have conducted a number of courses. The first practical pediatric endocrine course actually happened 10 years ago. So since then, we have got a lot of physical programs, but we also now have a lot of online programs which are there. So this is the third online program which we are doing because this provides a much wider access across the globe in that regards. We have our YouTube channel, which has got large number of videos which provide information about every aspect of pediatric endocrinology. There's also an online course which covers various aspects using validated tools. And we have got special courses, including the pediatric endocrinology for fellows, for postgraduates, fellowship in pediatric endocrinology, and a number of programs which are available online, which you can access through our website. We also run routine, regular postgraduate lecture series along with grand rounds using specific cases. So all these are concised in around 8 hours. These ones will run a long time and cover the entirety in that perspectives. And we have got publications which you can access and our mobile application, which will also showcase how it helps in terms of making point of care assessment and diagnosis possible. We are in the process of developing and probably will launch soon about our personalized intelligent EMR, which will allow our overall aspect of care using minimal inputs. Patients will get detailed output with regards to the likely diagnosis, likely evaluation and management. This will make connected clinics through using the e-system, making it much easier to whatever has been learned to implement in that regard. So recently, we have got a lot of programs. People have joined the fellowship program and the diploma program as well. So coming specifically on this International Practical Pediatric Endocrine course, we have got this 2-day program. First day is dedicated today on office endocrinology. We'll be covering growth, thyroid, puberty, and DSD. And tomorrow, we're going to cover the endocrine emergencies, mainly calcium, electrolyte decay, and hypoglycemia. So 8 modules. We've got Dr. Mudita Dhingra, who is from Kurukshetra. She did training under Dr. Sudha Rao in Mumbai. Vijay Vadia, very active in a lot of academic circles as well as the work, especially with regards to type 1 diabetes and obesity in the region of Kurukshetra. Dr. Deepak, who was actually my junior at AIIMS, he was doing his MD there, and now is currently in the Janki Medical College, Janakpur, very active again in that part of southern Nepal. Dr. Chetan, who was a fellow here, our first fellows, Dr. Chetan and Dr. Neha, he is currently working as a pediatric endocrinologist in Rajkot. Dr. Rajiv Bansal, a very senior pediatrician from Jaipur, who is a keen interest in quality improvement and to develop more skills and knowledge among young people. We will be joined by Dr. Vibha as well, who will continue with the case scenario. So before we go on to that, we need to understand why do we need glucose. So the body has multiple energy sources. The major areas which guzzle up or eat up energy is the brain. So when you are listening to all these talks or when you are preparing for examination, your brain is eating up all your glucose. The other areas are the heart, which is continuously pumping, and the muscles. So for that, and the RBCs, of course, because they're doing a lot of work. Glucose is a tool which can be used by anybody. Any of these organs will utilize glucose, whether it is blood cells, whether it is brain, whether it is the heart or the muscle. Ketone is an alternate source of energy, which is used predominantly by the brain and also by the muscle. So if you have less glucose and you have ketone, you will be fine. So situation, and we'll always talk about ketotic versus non-ketotic. So if you have a ketotic hypoglycemia, the brain will be preserved more compared to a non-ketotic hypoglycemia. So hyperinsulinism will cause much more brain damage than glycogen storage disease. You will have children with GSD who have a sugar of 20, 30, they will stand there in front of you. While if you have hyperinsulinism, if they have a sugar of 20, 30, they have no alternate sources, they will be really in a very, very bad scenario in that regards. Now, fatty acid can also be utilized by the heart, so again becomes important. Since a lot of hypoglycemia happens in the neonatal period, we need to understand the perinatal physiology. So we know that mother is the major source of glucose to the baby. All the glucose that baby has comes from the mother. It has no intrinsic production. So this glucose is basically a passive transport using GLUT1 and 3. And typically the baby's glucose are around 80% of mother's levels. But baby is very, very effective in getting glucose from the mother because this is what actually determines its growth. So what happens is that insulin can, of course, not cross the placenta, but the placental hormones like human placental lactogen, they induce insulin resistance. That is why a lot of women develop gestational diabetes. So anyway, increase in glucose is a normal phenomenon during pregnancy. Now this glucose will go up, so baby will get more amount of glucose. If you have got more glucose and you're not using anywhere because baby doesn't need to use that glucose now, it is of course going to increase insulin and inhibit glucagon. Increased insulin, low glucagon is an anabolic state. So fetus is basically just the only work of the fetus is to grow. So it is extracting glucose from the mother and causing fetal growth and causing glycogen deposition, which can be used later on when it is required, which is the postnatal period. Now, maximum of this happens in the third trimester. Now, as soon as the birth happens, there is a cut in this supply. So this supply goes down. So what is to be done? We have to use the resources which are available. So for this, epinephrine will go up, insulin will come down, and glucagon will go up. So essentially, you will have a lot of glycogenolysis, which will happen, gluconeogenesis, and a bit of lipolysis. Remember, ketogenesis is not effective in the first 24 hours. So if you measure ketones in the first 24 hours, everybody will be hypoketotic. So what I'm trying to say that first 48 hours, anyway, don't worry in terms of evaluation. So any neonate will have a fall, a dip in the glucose level. Maximum dip happens by around 2 hours. And after 48 hours, the metabolism, they become like adult. At 48 hours, a newborn's metabolism is just like an adult. The dip is greater for preterm neonates, and this has implications why they have much more likelihood of having hypoglycemia in that perspective. So this brings us to how do we define hypoglycemia in the newborn period. Now, if you want to define hypoglycemia, you need Whipple's triad. You need to have symptoms of hypoglycemia. You need to have low glucose, and this should not improve with basically, this should improve once you give a correction with regards to the treatment which happens with regards to the glucose. But in babies, you may not have all those symptoms which are there. So we use operational thresholds, which means when should we start worrying? So even if you are asymptomatic and glucose is below 25 in the first 4 hours, 35 between 4 to 24 hours, 50, 24 to 48 hours, and less than 60 beyond that, you have to worry. But if you have hypoglycemic seizures and your glucose is slightly higher, it doesn't mean that you don't need to worry. You have to worry also in that scenario. So when should you evaluate? If the hypoglycemia is persistent beyond 48 hours, you are needing a lot of glucose requirement, or there is no risk factor which is there in that perspective. You need to then evaluate for the cause of hypoglycemia, which becomes important in that perspective. Remember, glucometers are unreliable at low levels. So get a lab correction, which is very important in that regards. If you keep the sample in there and the orderly forgets about that, you will have low sugars because you will be eating up, the RBCs will eat up that. Similarly, if somebody has polycythemia, there will be a pseudo hypoglycemia which may happen. Be wary about that. Now, hypoglycemia theoretically can be because of a problem in either the glycogen metabolism or storage, problems in gluconeogenesis or ketogenesis. And there are basically 4 groups of hormones which act. We have got one which is causing hypoglycemia, which is insulin, and the counter-regulatory hormones are glucagon, cortisol, epinephrine, and growth hormone. So while insulin excess can cause hypoglycemia, deficiency of a single counter-regulatory hormone will not cause because there is redundancy. So when you have hypoglycemia, you are talking about multiple pituitary hormone deficiency, which is going to cause that in that scenario. So if you have hyperinsulinism, insulin will cause hypoglycemia, but your glucose requirement will be high, but there will be no ketones. That is a very important thing to remember. If on the other hand, you have a cortisol deficiency, you will have ketotic hypoglycemia, with hyponatremia. A problem in the glycogen metabolism, glycogen storage disease will not present right at birth because child is feeding every 2 to 4 hours. They will present after 6 months of age with hepatomegaly, renomegaly, ketotic hypoglycemia, lactic acidosis. That is a typical presentation. A gluconeogenic defect will present even later with predominantly lactic acidosis. A problem if you have in growth hormone or multiple pituitary hormone deficiency will present to you with other features like micropenis, midline defects. And if your ketone levels, you have problem in ketones, you will have episodic hypoketotic hypoglycemia. So hypoglycemia can be because of decreased production in which your glucose requirements are low, or increased utilization where your glucose requirements are more supraphysiological, more than 12 milligram per kg per minute. Decreased production could be a substrate issue like prematurity or SGA. Metabolic defects can be endocrine, in which you will have micropenis, midline defect, left palate, or metabolic defects like galactosemia or fatty acid oxidation defect. Galactosemia, you will have cataract, which is an important message in that regards. If there is an increased utilization, you may have a sepsis or a cardiac failure or hyperinsulinism. Hyperinsulinism typically will have a non-ketotic form of hypoglycemia. This could be transient, most commonly because of infant of diabetic mother, which resolves in 1 to 2 weeks. Prolonged, typically happening with a SGA baby. So SGA, birth asphyxia, prolonged for 2 to 6 weeks. And you have then rarer causes like genetic causes in which you can have severe forms because of potassium ATP channel defects and milder forms. So overall, if you ask me what are the most common persistent causes of hypoglycemia, it is hyperinsulinism, which you have to worry because this is causing severe damage. Your requirement is high, you need to evaluate and manage. And in hyperinsulinism, the most common is prolonged hyperinsulinism. So if your birth weight is low, think of prolonged hyperinsulinism. If there is macrosomia, early onset, think of infant or diabetic mother. Macrosomia and persistent beyond 2 weeks or 1 week, think of a potassium ATP channel defect in that regards, and you require that. So if an individual becomes hypoglycemic, you should definitely have zero insulin. There should be a ketone which is significantly present. Cortisol should be above 550. Often we just compare to a normal range, but it is not normal. It has to be appropriately elevated. And you expect the growth hormone to be high. So all this you need to remember when you assess a critical sample. So the most important thing to do in a child with hypoglycemia is to check the critical sample. Most important is ketone, cortisol, insulin, maybe growth hormone, lactate. This will be something which will be important in that perspective. So if you have any detectable insulin during hypoglycemia, this is hyperinsulinism. If ketone is low, everybody who is hypoglycemic should be ketonic. The most important investigation in hypoglycemia is ketone. If your ketone is low, think of fatty acid oxidation defect, galactosemia, or GALT abnormalities in there. If your lactate is high, it is glycogen storage disease or a gluconeogenic defect. If cortisol is low, think of MPHD in that regards. So ketone is very important. If your ketone is less than 0.6, it is hyperinsulinism or galactosemia. Do a urine reducing substance and an insulin level. If ketone is mildly elevated, it can be a fatty acid oxidation defect. You look at acyl carnitine profile and genetic study. If ketone is more, a lot of workup needs to be done here. Look at organic acidemia, accelerated starvation, reducing substance, insulin, all those things might need to be done in that scenario. Now, often people say we don't have blood ketones. Can we use urine ketone? For DKA, the answer is no, but here you can, because here you want to know whether it is there or not. And urine ketone may be there for a longer time. So maybe you have corrected the hypoglycemia, but still urine ketone may be positive. So if you have a confusion, you can also check urine ketone in that perspective. Finally, if your ketone is low, think of hyperinsulinism and fatty acid oxidation defect. If your lactate is high, think of a GSD1 or gluconeogenic defect. If there is acidosis, again, the same scenario with organic acidemia. Insulin, anybody with detectable insulin is hyperinsulinism, and rarely you will require a glucagon test. So the most important tests are ketone, lactate, and insulin, along with, of course, cortisol, which will give you an appropriate picture. If you have persistent hypoglycemia, your cortisol levels in stores may be exhausted. So you may find that somebody who has high glucose insulin requirement, high GIR, insulin is high, ketone is negative, but cortisol is also low. This is because of an exhaustion response. And don't get confused that this is actually a cortisol deficiency in this scenario. So just look at ketone. If the ketone is low or absent, look at reducing substance. If it's positive, it is galactosemia or fructose intolerance. Negative, look at insulin levels. If they are undetectable fatty acid oxidation defect, if they're detectable hyperinsulinism. If ketone is high, look at lactate. If lactate is high, it is GSD1 or gluconeogenic defect. If it's normal with organomegaly, this is rare forms of GSD. If there is no organomegaly, look at cortisol and GH, and then you diagnose. So look at ketone, look at lactate, look at organomegaly, you will get the diagnosis. And it's that you have got less amount of sensitivity for a detectable insulin. Look at other parameters also in that regard. So hypokalemia and a high GIR are also indicators of hyperinsulinism. So in hyperinsulinism, first exclude transient and prolonged forms. If they are there, treat with dextrose and diazoxide. If they are not there, look at diazoxide response. If it is present, you continue diazoxide, look at ammonia, which may give you an indication for a form, genetic form, which we'll discuss in a case also. If that is not there, go for potassium ATP channel defects. If there is a recessive defect, then you can go for a palliative surgery because it's a permanent form usually. If it's a paternal abnormality, you can go for a focal form and evaluate from that in that perspective. So we have discussed about the various causes, pathophysiology, and assessment with regards to that. We'll now move forward towards the case scenarios. Dr. Vibha, you probably please continue.
Thank you so much, sir. We have this 6-hour boy, and we got a call from NICU because his blood sugar was 36. So, Dr. Mudita, what would you like to do in this case? Should we go for the extensive evaluation in this case?
Yeah, good evening, everyone. So this is a 6-hour-old newborn baby with a blood glucose level of 36 milligram per deciliter. Yes. So as we know that hypoglycemia is very common in newborns and it can have devastating effects regarding to the neurodevelopmental outcome. But we need to be careful in diagnosis of hypoglycemia. Right. So as sir explained it very well that there is a transitional phase from till around 48 hours when the glucose regulatory machine is still developing. And there is a physiological dip in blood glucose level both in the term and preterm babies. So this physiological dip is normal, and in this child, the baby is only 6-hour-old with a blood glucose level of 36 milligram per deciliter, and baby is asymptomatic. Right. So I think this baby doesn't need any evaluation and just requires frequent feeding.
Very well said. Ma'am, what key messages would you like to give?
So yes, I just said that we need not.
Yes, ma'am. And when we should evaluate in the cases like when we got a call from the NICU for hypoglycemia.
Yes, so whenever we get a call for hypoglycemia to NICU, we have to look into the details of the history, whether the baby was preterm, term, post-term, or whether there is any risk factor, for example, birth asphyxia, whether the baby was SGA, right, whether the mother had gestational diabetes or any drugs. So all these history we have to take in detail and then only evaluate a baby with hypoglycemia. And as I said that the transitional phase lasts for around 48 hours. So any hypoglycemia which persists beyond 48 hours requires investigation.
Right.
Another indication would be the GIR requirement of more than 12 milligram per kg per minute. So as we know that the glucose output by the liver is at the rate of around 4 to 6 milligram per kg per minute. Yes. And whenever there is substrate deficiency or endocrine deficiency, whenever we replace IV fluids with a GIR of 6 to 8 milligram per kg per minute, it suffices. But whenever the GIR requirement is very high, it requires detailed investigation. So all these cases will require investigation if there is any risk factor, if the hypoglycemia persists beyond 48 hours, and if the GIR requirement is more than 12 milligram per kg per minute.
Okay, thank you, ma'am. So any key messages, ma'am?
So yeah, this baby didn't need any evaluation because this baby is asymptomatic without any risk factors, and the blood glucose is 36 milligram per deciliter at 6 hours of life. So
Thank you
when
so
we
much,
consider, thank you. So this is only transitional hyperglycemia.
Thank you so much, ma'am. Now moving towards the next case, we have this 3-week-old boy, and we got a reference call from the NICU because he was having seizures and his blood sugar was just 28. And when we examined the child, he had micropenis also. So, Dr. Deepak.
Okay, so this neonate has already passed the transitional phase, and now he's having syndromatic seizure along with the visible micropenis. So immediately our mind should think about whether this child is having some pituitary issues like multiple pituitary hormone deficiency. So we should examine this newborn in detail for such features like single incisors, cleft palate, nystagmus, or any other stigmata which suggest this neonate can have multiple pituitary deficiency.
Right.
Besides that, we can take the help of our lab also. So may I know what is the lab value for investigation in this newborn?
So what investigation we should order for? First investigation, what investigation we should
So first we have to identify whether this child is having ketotic hypoglycemia or non-ketotic hypoglycemia. So ketone will be the first, because this child is also having seizures. So electrolyte, calcium, magnesium will be also prudent in this case.
The ketones were 2.3. It was greater than 2. So it was.
So it's 2.3. So in a way, it rules out hyperinsulinism. So our aim should be to evaluate whether this newborn is having GSD or some other illness. But because this newborn is having micropenis, so straight away we can think of some pituitary issue. So we have to identify like that.
And so when we further evaluate the child, we found that sodium is also on the lower side. It is just 128 and the lactate is 1.2, which is the normal levels.
So I guess this child doesn't have any organomegaly too. So straight away this child is having hyponatremia with normal potassium, suggesting cortisol issue along with hypoglycemia. So probably this newborn is having multiple pituitary hormone deficiency. So we have to measure the function of pituitary.
Yes, sir. When we get the cortisol levels, they were quite low. It was just 125 and growth hormone was 4 nanogram per m. So you were right. It was the case of multiple pituitary hormone deficiency. So, sir, what key messages would you like to give from this case?
So in any newborn who is having hypoglycemia, which is prolonged, we have to rule out certain key problems like hyperinsulinism, multiple pituitary hormone deficiency, and some inborn error of metabolism. So like in this case, there is glaring micropenis. So we should not forget to examine this newborn for signs of multiple pituitary hormone deficiency like micropenis, cleft palate, nystagmus, single incisor.
And I think the other big message was that the cortisol level was reported as not very low, and the growth hormone was also reported as normal, but we need to understand that this is inappropriately low for the level of hypoglycemia. So that is another big message we have to consider.
Thank you, sir. Thank you, Dr. Deepak, for this wonderful message. So moving towards the next case, we have this 10-day-old girl with the hypoglycemia, but the glucose requirement was high, that is 14 milligram per kg per minute, the undetectable ketone, and the urine reducing substance were negative. So, Dr. Chetan, are you there? Dr. Chetan?
So if he's not around, I can take that.
Okay, sir. Sir, could you please, Dr. Deepak, please help me with this case. How should we proceed in this case, sir?
Okay, so this again, neonate is having hypoglycemia, which is prolonged beyond the transitional phase with hypoketotism and high glucose infusion rate beyond 12 milligram per minute per kg per minute. So indirectly, it tells us this child or neonate is having features of hyperinsulinism. So we can examine him for such things like in hairy pinna, increase in the pinna, omphalocele, or some other features of hyperinsulinism.
Right, sir.
So was there anything like that, suggesting something like that?
So there was the examination has some features of a hairy pinna, and when we get the insulin levels done, it was 3 mil. It was in the normal range.
Okay, so basically, whenever the glucose is low, along with high glucose infusion rate, there is no business of insulin to be there in the blood.
Right.
So it tells us this child is having hyperinsulinism. Though this is reported normal, but this is inappropriately normal.
Yes,
it should
sir.
not be there. So this
Yes.
child is having hyperinsulinism.
So, sir, in this case, we did the glucose response. As sir already mentioned that the sensitivity of glucose response is 100%. So, specificity of glucose response is 100%. So, we did the glucose response, and there was a rise in the this glucose. So, what would you like to give us a message from this case?
So the message is, whenever the high glucose infusion rate is there in any newborn, we should always think of hyperinsulinism, and we have to work for that, because there is treatment available either in form of drug, or if it is prolonged, we have to go for pancreatic evaluation, whether he needs resection or some other form of treatment. So investigation like insulin, C-peptide, ketone. So we have to take the critical sample at the time of hypoglycemia, and based on our clinical diagnosis, we can ask the lab to give the report.
Rightly said, sir. What key messages would you like to give from this case, sir?
So because this child is having hypoglycemia with high glucose infusion rate and ketone was negative, so this child is having hyperinsulinism, and we have to think of that, because if we miss that, long-term outcome will be very bad in this case of in this kind of scenario, because of repeated hypoglycemia and brain damage.
Thank you so much, sir, for this wonderful message.
So I think this is a very important scenario of hyperinsulinism, which is a common scenario in which there can be so much confusion which is there.
Her birth weight was 3.4 kg, and this very low ketone, and the glucose requirement was high, that was 12 milligram per kg per minute, and on the urine there was no reducing substance found, and the insulin was detectable, and what we found that the growth hormone and the cortisol was also low in this case. So I was not able to conclude this case. So Dr. Rajiv, could you help me with this case?
Good evening, everyone. This is an interesting patient and almost similar to the one which we had discussed earlier. But the important thing to note in this child is the low growth hormone levels and cortisol levels of 120. Ideally, in a normal setting, when there is hypoglycemia, there should be an exaggerated response with cortisol and growth hormone. It seems that, to be very sure, that is because of hyperinsulinemia, we have to do a glucagon challenge test with 30 microgram per kg of glucagon. If there is a response with increase in glucose levels, that suggests that's because of hyperinsulinemia. But why growth hormone levels and cortisol are low? It seems that there is an exhaustion of the stores of cortisol and growth hormone because of there is an appropriate glucagon response. It seems there is, because of this exhaustion, the levels of cortisol and growth hormones are low. So this is an important condition, and one should not be misguided if the cortisol levels are low.
Yes, sir. We done the glucagon response, and it was present. There was a rise in the blood glucose. So as you have correctly mentioned, yeah, this was the case of hyperinsulinism, not the multiple pituitary hormone deficiency. So, sir, what key messages would you like to mention here?
So the key messages are that high glucose infusion rate suggests hyperinsulinism, and cortisol exertion with prolonged disease can occur, and one should not go in. One should always measure and see to it that is that multiple endocrine defects should be seen, like central midline defects should also be observed before we come to a conclusion for those conditions.
Thank you so much, sir. As sir has already mentioned, and Dr. is already mentioned by the Dr. Rajiv, that if we are dealing with a patient with hyperinsulinism and we also have low cortisol and the low growth hormone levels, so it could be the cause due to the cortisol exhaustion, and we should go for the glucagon response to confirm the diagnosis of hyperinsulinism. So now moving towards the next case, we have this 2-day-old girl who was admitted in NICU, and she had episodes of seizures. When the blood glucose was measured, it was just 24, and the ketones were very undetectable. There was no reducing substance in the urine, and there was detectable insulin. So, Dr. Deepak, how should we approach these cases in NICU?
Okay, so because this newborn is still only 2 days, so ketone value probably may not be having so great importance, but this newborn is having seizure along with hypoglycemia, but insulin is there. So it suggests some form of hyperinsulinism is there. So we have to go into the history, whether this mother had RS negative blood group, PIH or eclampsia, or there was some HIE like of scenario, or
Right,
there
sir.
was some diabetes in the mother. So can you give some?
Yes, sir. Mother has a diabetes, and the birth weight of the baby was 4.4 kg. So it was.
So, and what was the glycosylated hemoglobin level?
Sir, it was 8.
Okay, so it tells us this mother had pregnancy-related diabetes. So probably this baby is infant of diabetic mother with hyperinsulinism. So it need to be monitored and managed like hyperinsulinism.
Right, sir. And so what examination, what important point should we do in the examination while examining the baby?
Okay, so this baby will have normal head circumference with big broad shoulder with hairy pinna, and there will be polycythemia like of chubby looking baby, and maybe some hepatomegaly too.
Okay. So what this key messages would you like to give here?
So any newborn who is having hypoglycemia again need to be taken care regarding different etiology, particularly looking towards the endocrine aspect. We have to think about hyperinsulinism, and we have to go systematically with the history. If it suggests, we have to go for the workup of hyperinsulinism, including ketone, insulin, or C-peptide levels.
Thank you so much, sir. So it is very important to ask for the maternal history in the patient, in the baby of hyperinsulinism. If the birth weight of the baby is like this, in this case, more than 3 kg. So never miss to take the maternal history and never miss to examine the baby properly. So thank you so much, Dr. Deepak. Now moving towards the next case, we have this 14-day-old boy, and he has a history of birth asphyxia during the birth, and so he was admitted in the NICU for this. The blood sugar was 28, so we got a referral for this. The glucose requirement of this baby was high. It was 40 milligram per kg per minute, and the ketone was undetectable, but there was a detectable insulin. It was 4.2. But as we have seen in all previous cases, when we have detectable insulin like hyperinsulinism, we expect the birth weight to be high, like more than 3 kg. But in this case, it is just 1.6 kg. So I'm not getting with this case. So Dr. Mudita, could you help me in this case? What would be the cause of this? Is this birth asphyxia and this low birth weight and this hyperinsulinism all are related?
Yes, so we'll see all the things step by step. The first point is the age of the newborn. The baby is 14-day-old, so the baby is out of the transition period of the transitional phase of adaptation, and the baby has already 2 risk factors: the birth asphyxia, and the second is the birth weight of the baby. So baby is clearly SGA baby with history of birth asphyxia. Then the next step is the GIR requirement. So as I already explained that the GIR requirement, if the substrate requirement is high, or there is increased utilization of glucose by increased insulin level, only then the GI requirement is so high. So this baby has clearly hyperinsulinism. That is why the baby is requiring such high GIR. And there are 2 risk factors for that, birth asphyxia and the SGA baby. So what happens typically in these babies is there is prolonged hyperinsulinism. So hyperinsulinism, when we talk about, they are of 3 types. The one is transitional, which usually
is by far one of the most important causes we are seeing, and they will respond to diazoxide. This is a very important message at this point of time. And now what happened on follow-up, Dr. Vibha?
And on, as ma'am has already mentioned, and we started that diazoxide with the 10 milligram per kg per minute. And so the glucose requirement has decreased, but the baby has developed edema. So, Dr. Chetan?
Yeah, hello. Good evening, everybody, and thank you, Dr. Anurag and the team.
Sir. Sir, could you please explain what is the cause of this developing edema in this baby when we started diazoxide?
Yeah, so this was a case of clear-cut hyperinsulinism, which responded to moderate dose of diazoxide as well. The usual dose of diazoxide is 5 to 15. Usually we start with the 10, but a non-effect, or we can say adverse effect of the diazoxide is fluid overload. Right. So definitely this looks like this edema is due to the diazoxide itself. So it has been said in the guideline as well that along with the diazoxide, we should use the diuretic, that is hydrochlorothiazide. And another is we should not use any other diuretics like furosemide and all due to the risk of hypokalemia. So along with the diazoxide, we can use a minor dose of hydrochlorothiazide as well.
Right, sir. Sir, as you have already said, we started the thiazide for this edema, and the edema has reduced. So, and sir, how should we taper it? For how long? Like it should be gradual taper, or we should suddenly stop?
Yeah, diazoxide should be always gradually tapered. Even we used to give advice to the patient that even they should be checking the blood sugar at home as well, preferably 3 to 4 times a day. Whenever the sugar goes above 100 or remains persistent above 100, we can decrease maybe 1 milligram per kg per day every few days. So it can be tapered over 2 to 3 months. Usually most of the temporary hyperinsulinism responds by 8 to 12 weeks of the therapy. So yes, it should be gradual along with the sugar management, and the parents or the relative should be explained regarding the management of hypoglycemia if at all occurs, and we should give them a target of at least 70 milligram per deciliter of the RBS.
So what key messages would you like to give here? And with what side effects the patient should be aware of the diazoxide can cause in the baby?
The most important diazoxide is most important side effect is as this case is undergoing, that is edema and weight gain. Another few less common side effects are hypertrichosis as well as low platelet as well. So any unexplained bleeding or blood in stool should be directly or managed on an emergency base. So this was a case of prolonged hyperinsulinism, which can occur with the SGA baby. Diazoxide is the first line of management, but again, I would say that before starting diazoxide, a normal 2D echo is must, because we have encountered many cases which are on air maintaining SpO2, but whenever we start the diazoxide, this minor PPHN or PAH gets aggravated. So definitely 2D echo should be done before starting diazoxide. Diazoxide we can start in the moderate dose, say approximately 10 to 12 milligram per kg per day in 2 to 3 divided doses. We should be monitored for the side effect, particularly the weight gain and edema.
Right, sir.
And we should always use hydrochlorothiazide along with the diazoxide.
Thank you so much, sir. Now moving towards the next case, we have this 15-day girl, again with a hypoglycemia, and her birth weight was 3.2 kg. And again, this glucose requirement was high, 14 milligram per kg per minute. And this very undetectable ketone, hypoketotic, the detectable insulin. So, Dr. Rajiv?
What was the lactate levels?
So,
what are the urine reducing substance?
So, yeah, let's come to this. Yeah.
Was it normal or it was negative? Sorry,
Yeah,
it was negative urine.
So it was negative.
Okay, so if you have a urine reducing substance negative with hyperinsulinemia and the ketones are low, you are left with only one diagnosis, that is hyperinsulinism.
Right.
And with hyperinsulinism, the treatment, as we had already discussed, is the treatment with digoxide. And if this patient responds with digoxide, that means that we see that it excludes, a digoxide response excludes almost all causes of severe congenital hyperinsulinism. And in all these cases, one need to do ammonia levels,
yes,
because sometimes we get some mildly raised ammonia levels of the tune of 80 to 150 or 160 moles per liter. And if the ammonia levels are high, that suggests that the patient might be having HIHA syndrome. So
yes,
this has always to be excluded in these patients.
Yes, when we get the ammonia levels done and it was high in this case. So you have already mentioned ki it could be it is the cause of HIHA. So, sir, what are the key messages would you like to give?
The key message is that the digoxide response is key to the diagnosis of the underlying cause of hyperinsulinemia, and one should always measure ammonia levels, which are invariably in a mild form.
Right, sir. Thank you so much, sir, for this wonderful message. Now, coming to the next case. Now, we have this 6-month boy. He come to us with lethargy and blood sugar was 36. The parents brought him to the OPD. So, Dr. Mudita, what could be the cause of this suddenly low blood sugar in the 6-month-old boy?
Yes, so as now we are moving towards beyond neonatal age group, and this baby is an infant, 6-month-old with hypoglycemia, and the baby is symptomatic.
Right.
So we need to understand the physiology first. So whenever the mechanism of glycogenolysis, gluconeogenesis, and ketogenesis are intact, the baby can tolerate fasting of around 6 to 12 hours. But in this case, when the baby has already developed hypoglycemia at 6 months of age. So the first step in investigation would be the ketones.
Right.
And are the ketones present or absent in this baby?
Yes, ketones are present.
Yes, so this is ketotic hypoglycemia, and the next step to evaluate is the serum lactate level, which is also very high.
Yes.
Which is also very high. So it points towards the diagnosis of glycogen storage disorder, and this baby already also has hepatomegaly. So
right.
As the name suggests, it is glycogen storage disorder. So glycogen is deposited in organs like liver and muscles, and it is not released in the form of glucose in the bloodstream. So there is defective glycogenolysis in these children, and hence they develop hepatomegaly and hypoglycemia.
So ma'am, what are the key messages here?
So yes, whenever a baby presents with hypoglycemia beyond neonatal age group at around 6 months of age or in infancy, and there is presence of high lactate, high ketones, and hepatomegaly, it points towards the diagnosis of glycogen storage disorder. And we will manage these children with frequent feeding, and maybe some children might require nighttime nasogastric feeding or added cornstarch in the feeds. So they will not tolerate prolonged hypoglycemia or prolonged feed gap.
Thank you so much, ma'am. So now we have a next case. We have this 6-week boy who came to us with failure to thrive. He was not gaining weight, and his blood sugar was 60 with the normal glucose requirement. He has hepatomegaly. So, Dr. Deepak, is this case similar to the previous case?
No, the age group is slightly different, and here the hepatomegaly is also significant. So this tells us this newborn or infant is having some form of inborn of metabolism relating to liver. We have to examine for that and investigate for that. So what is the ketone level?
Sir, ketones were low.
Okay, so now this child is having hypoketotic hypoglycemia. So we have to decide whether this child is having hyperinsulinism. So it doesn't seems to that because of the physiological glucose requirement. So we are left only with the galactosemia like issues. So what is the urine reducing sugar?
So they were present in the urine.
Okay, so it is probably galactosemia, I think.
So what key messages would you like to give here?
So hypoglycemia, either in neonate or beyond neonatal period, it's abnormal. It has to be investigated because there are plenty of treatable causes. We have to find out the cause. Otherwise, if we just treat symptomatically with glucose or glucose infusion in the NICU and do not investigate, many cases will go unrecognized and will have devastating consequences.
Thank you so much, sir. Moving towards the next case, we have this 1-year-old girl, and the parents were really scared that she was not waking up in the morning. When they checked her blood sugar, it was just 24. And when we examined the girl, there was no hepatomegaly. So, Dr. Chetan, could you please explain us what's going wrong with this girl?
So first of all, this is a big boy, big girl. She is 1 year old.
Yes,
so
sir.
Definitely we should be taking history regarding what she has taken in diet the day before the event happened, whether she was ill or not, she had taken proper dinner or not. And now if we come to the actual case scenario, so definitely this is a hypoglycemia in a 1 year old girl, so which is always significant with no hepatomegaly. So as our algorithm suggested, first we should be measuring ketones, whether it is hypoketotic or ketotic. So we know that the hypoketotic hypoglycemia are 3 causes, which is generally don't present at this age or at this age. So can you tell me the ketones?
So
Yeah, so ketone were 3.3. So definitely, yes. So lactate is normal.
Yes.
So all metabolic disorders are out with the ketotic hypoglycemia. So we have now few diagnoses, that is endocrine deficiency in form of hypopituitarism versus accelerated starvation or idiopathic ketotic hypoglycemia. So we should be analyzing the cortisol as well as growth hormone from the critical sample to get the next clue.
And so when we get the cortisol and the growth hormone levels, they were in the normal range.
So cortisol and growth hormone were high at the time of hypoglycemia, suggestive of endocrine sufficiency. So there is no issue regarding the any of this hormone deficiency, leading to the last diagnosis, that is accelerated starvation. But let me tell you that this is the diagnosis of exclusion. One should not jump on the accelerated starvation just based on the early morning hypoglycemia, symptomatic hypoglycemia. We should be evaluating in terms of ketone, lactate, growth hormone, and cortisol as well. And then we can stem the diagnosis of accelerated starvation.
So how could we prevent this accelerated starvation in a 1-year-old child?
Yeah, so if it is a case of accelerated starvation, which is generally present in the failure to thrive, or we can say growth failure children. So we should be focusing on nutrition. Building up on nutrition will be the key. So maybe some protein diet as well. Asking the parents not to leave the child more than 6 hours of fasting at any time, preferably giving cornstarch diet that will release slowly carbohydrates during the night, maybe a bedtime milk or bedtime snack before going to bed, as well as this kind of babies, whenever they feel sick, they are tend to get hypoglycemia. So prompt treatment of the sickness, maybe frequent ORS and frequent carbohydrate related diet as well as liquids. This all will prevent the symptomatic hypoglycemia.
Okay. So what key messages would you like to give here?
So key message again, ketotic hypoglycemia. We should be doing all investigation before labeling them as accelerated starvation, particularly endocrine deficiency. And if the child is having short stature with maybe a normal weight, or there is midline defect, then we should be definitely looking for the cause of hypopituitarism. So growth hormone, cortisol are the key investigations in the ketotic hypoglycemia.
Thank you so much, sir, for this wonderful message. Now moving towards the next case, we have this 2-year-old boy, who came to us with failure to thrive. He has complained of vomiting, lethargy, and his blood sugar was quite low. It was just 28. Ketones were present in the blood, and the lactate were low. And the diagnosis of accelerated starvation was made. So, Dr. Rajiv, do you agree with this diagnosis of accelerated starvation here?
So as what Dr. Chetan has already elucidated so nicely, that we should not accept a diagnosis of accelerated starvation at the face value, and we should always investigate our patients for other detailed things, and we need to take some examination and history. So we need to find out if there is any organomegaly with this in this patient, and what about the lacrimation of this patient. If there are patients who have alacremia, or the patient who has had a persistent vomiting might be vomiting a food particles which he or she has ingested, say within the last 1 week's time, which is not a fresh food which is coming out. At the same time, we need to see for any evidences of pigmentation in these patients. And if we find pigmentation, or we find evidences of alacremia or vomiting which has been with food particles ingested earlier, we should give a very detailed workup on these patients and find out what are the levels of cortisol and growth hormones, other hormones in these patients. If what is the cortisol level in this patient?
So the cortisol level was low.
So this clearly shows us that this patient has got an endocrine background with low cortisol levels and pigmentation in this patient. He's having endocrine problem, which could be one of the important diagnoses which one need not to forget is a AAA or L group syndrome, or in these patients. A AAA syndrome should also be considered.
Right. So as you have mentioned that there is, when we asked the parents, they told us that when he cried, there was no tears. So alacremia was there, and pigmentation was there, and the cortisol was also on the lower side. So yes, the sodium was low and the potassium was 4.2. So as you have rightly mentioned, there was eclampsia and there was AAA syndrome. So sir, what key messages would you like to give here?
So we should always be lookout for these grown-up children for ketotic hypoglycemia, should consider accelerated starvation. But however, we should not leave it at accelerated starvation until we have fully evaluated these patients, and we should look for all other causes and see telltale signs of evidences like pigmentation, alacremia, etc., and should get their cortisol and growth hormone levels done to come to a final diagnosis.
Thank you so much, sir, for your valuable input here.
So I think this was a wonderful discussion which happened here with regards to hypoglycemia. I'd like to thank all the panelists. I'd like to thank Dr. Deepak, Dr. Bansal, Dr. Chetan, Dr. Mudita, and Dr. Vibha for providing us with this wonderful discussion which is there. I think hypoglycemia is one problem which is extremely common. Unfortunately, it is either missed or missed. Often we tend to not evaluate it properly, or often there are issues in terms of management which happens in this perspective. So Dr. Mudita, your take about prolonged hyperinsulinism, do you think this is something which is often missed by pediatricians?
Yes, so it is a very common scenario in India. You know, whenever there is a sick newborn, SGA, the SGA baby already has risk factor of developing prolonged hyperinsulinism. And usually pediatricians keep on thinking that, okay, this is SGA baby, the glycogen reserve is low, so the child can have hypoglycemia. But we have to look into the case carefully and look into the GIR requirement. So if the GIR requirement is very, very high, we have to rule out hyperinsulinism, and that will be beyond 48 hours of life. So after 48 hours of life, we have to be very careful and not wait till 7 days, 14 days, which was previously suggested.
I think a lot of people tend to give hydrocortisone as part of treatment. Dr. Chetan, what are your suggestion about pediatricians who give hydrocortisone irrespective of cortisol levels in hypoglycemia?
Yeah, we often came across, or we often called after they have given first dose of hydrocortisone, and this is the common practice. Even some of the neonatology guidelines say the large dose of cortisone in mg per kg per day. which can temporarily elevate the sugar. But again, that might be due to exhausted cortisol reserves, and we should not be using hydrocortisone before documenting proper cortisol deficiency, because it will lead to a misdiagnosis of the underlying hidden hyperinsulinism or any other cause. So definitely no hydrocort before going for the cortisol from critical sample.
And I think one big thing that we have observed is that cortisol levels are often low in these scenarios,
Yes.
and they are not usually persistent. So this is again a big
Yes.
message that if you have a low cortisol, a single value, because there are a lot of issues in terms of infant cortisol evaluation, there are issues of exhaustion. You may have a false diagnosis of cortisol deficiency, which is done. So we have to be very, very cautious in that perspective. So Dr. Deepak, I think one of the common scenarios that you were discussing also is about ketotic hypoglycemia, which is often people. So there are two things. One, in the newborn period, they say it's transient, nothing to worry. Even if it is 1 week, there's no evaluation done. The other is this ketotic hypoglycemia. So what are the telltale signs that this child doesn't have ketotic hypoglycemia? You need to worry more about somebody presenting at 1 to 2 years of age with hypoglycemia.
So any child who is presenting beyond neonatal period, sir, with hypoglycemia has to be investigated, in my opinion, because there must be some underlying cause. Even if you think of either accelerated ketotic hypoglycemia. So big sign for hyperinsulinism will be, sir, hepatomegaly. There will be, sir, frequent hypoglycemia or seizures. But I think, sir, there will be history of prolonged during neonatal period that he'll be ill, requiring multiple episodes, improving with glucose boluses. So that history should be taken into consideration.
I think that's a very, very valid and important point, and a key message coming that you have to look at signs like whether there is any feature of pigmentation. As Dr. Bansal talked about, this becomes very relevant, and assessment of anybody who is beyond 48 hours.